Good evening, everybody, on a rainy night in Dublin. My name is Graham Love. I'm the CEO of the Health Research Board, and I'm delighted to welcome you here to this Hrb Red Alert in partnership with Science Gallery. Hrb is a government agency that funds medical and health research, so we're very interested in things like blood. So this is a natural sort of partnership for us. And we have a particular treat for you here tonight, and a particular aspect of this. We're going to be discussing something that's very current and interesting in the world, Ebola. I'm sure you would have to have been living on another planet not to be aware of it over the last few months. And we're bringing a little flavour of it here tonight, which involves basic science, the clinical world, and the view of journalists. And I'm not going to steal the MC's thunder too much, other than to first say I'm delighted for the Hrb to be partnering with the Science Gallery on this, and then to hand over to somebody who's a fellow ex-student of mine, a professional colleague of mine and a friend of mine, Claire O'Connell, a freelance journalist I think many of you will know, not least with her many science articles in the Irish Times, Nature, Silicon Republic and others, well placed to MC this event tonight. So I hope you'll have a very entertaining conversation panel, and at that note I'll hand over to Claire. All yours, Claire.
Thank you, Graham. Thanks very much, Graham. No pressure there, obviously. So welcome, everybody, this evening. Thanks for coming along. It is an absolutely revolting night outside, so we really do appreciate the effort that you made to get here. This evening we're going to be talking about, as Graham said, Ebola, and we are going to have a conversation between these three very distinguished panellists and guests, whom I'll introduce in a moment. I think Ebola is one of those things that is a standout for 2014. Sometimes towards this end of the year we start to look back on the big stories, and certainly when I think the archivist in RTE eventually goes in to pull up the database for 2014 when they're making reeling in the years, Ebola is definitely going to be one of the things that they feature. I suppose Ebola, the virus, has been known to science since the mid-1970s, 1976 I think it was discovered. In the almost 40 years since then, until March 2014, it had killed around 2,500 people that we know of. Since March 2014, it has killed 6,833 people that we know of. And as I say, they are just the reported cases. So that will show you the magnitude of what's going on at the moment in West Africa. We have also seen cases outside West Africa, and I think we'll talk a little bit about later about the type of the fear and sometimes the paranoia, the Ebolanoia that creates. But just to briefly introduce my guests and let each of them tell you a little bit about their own interest in Ebola before we start the conversation. On my left we have Professor Cliona O'Farrelly, who is Professor of Comparative Immunology at Trinity College Dublin. Cliona is very interested in how the immune system works, and particularly how the immune systems of different species work, and even the different portions of the immune system in our body work. So, and Cliona also, I should mention, recently won a 2014 Nature Award for mentoring in science. So congratulations on that, Cliona. I suppose if you can tell us a little bit about your own interest in Ebola from your own perspective.
Well, one of the things I'm really interested in when studying the immune response to various stimuli is why is it some people are resistant to certain infections. So we all know about women getting contaminated anti-D, HCV contaminated anti-D, and we've heard a lot about the type of immune response they make. But there was a significant number of people that were women who were exposed to hepatitis C infected anti-D but did not get infected, and who did not make antibodies and didn't have T cells. And so we think it's their innate immune system. So there's something very akin to this situation with Ebola. There are clearly a significant proportion of people who can resist the disease by different mechanisms, if only we could find out how.
Okay, and obviously that would be very important for developing things like vaccines and treatments, and we can talk about this a little later on. Dr. Colin Brown is an infectious diseases registrar with King's College in London, and he is infectious diseases lead for the King's Sierra Leone Partnership, which I'm sure you'll tell us about shortly. Colin has been out in Sierra Leone twice this year already. He's just back a few weeks from his most recent trip, and he's looking to develop capacity over there in the field of infectious diseases, not just Ebola, but also things like tuberculosis, HIV, and laboratory diagnostics. So Colin, I mean, obviously you've been out there in person, so can you tell us about your own interest at the moment in Ebola?
So I'll say a little bit about King Sierra Leone Partnership. So we've been based in Sierra Leone for the last 2 years, pre-existing Ebola, and very much as part of a long-term strategic plan to be there for 20 years, trying to work with the main hospital, the only adult referral hospital, the educational facility, so the medical and nursing school, and the government, trying to support and strengthen health infrastructure there. We never really planned to do any clinical work, but when Ebola took off, then we got involved, and we've now seen probably a quarter of all the cases around the Freetown area in just one of our sites alone, and we manage 4 sites across the city. My interest in viral hemorrhagic fevers predates that. I've looked after a couple of viral hemorrhagic fevers in the UK, in the isolation unit that we have in the Royal Free in London, and was always very kind of interested to see it in the field. I have to say now, if I never see another case, I'll be very glad. So I've been back twice, both working clinically. So about half my time is working clinically, and half the time is working with the National Ebola Task Force of Sierra Leone, looking at operational issues and how do we scale up capacity and get diagnostics and get flow and structure better.
Okay, great, thank you. Maryn McKenna is a journalist whom I'm sure many of you know her work well. She covers the infectious disease beat and has done so expertly for a number of years now. She's the author of 2 books already, and I think another one is cooking, possibly. Okay, and she has worked very closely with the Centres for Disease Control. She writes for Wired. She's a blogger for National Geographic and contributing editor for Scientific American. And she also coined the phrase and started the hashtag Ebolanoia, which, if you want the Urban Dictionary definition, it's a noun: the irrational fear of contracting Ebola in a country that is not experiencing an actual Ebola outbreak. So, Maryn, you have a very interesting perspective on Ebola.
I didn't realize we had an Urban Dictionary entry yet. So, yeah, thank you for that, Claire. As you can tell from that introduction, I've lived my life as a journalist pretty close to public health authorities. And so I've gotten to see really up close how people are fascinated by scary diseases, that we're both attracted to them as a subject and repulsed by them. And I think that's been particularly important in Ebola, that people are weirdly interested in it and yet terrified of it, probably out of scale to its actual risk, at least to the risk of posed to people outside the endemic countries. And certainly in the United States, and I think in some other countries as well, public policy around Ebola has been driven by fear of Ebola, really by Ebolanoia, much more than it has been by the actual reality of the disease, in some cases to enormously costly and really time-wasting results. So that's the position from which I'm coming to this subject.
Okay, maybe we can explore that Ebolanoia a little further, because I think you know, the mismatch between the reaction of people in countries like the United States, for instance, and the actualities of what's happening in Sierra Leone. If it weren't so awful, it would be funny. So can you give us some examples of what has been born of the fear of Ebolanoia?
So here are just a couple of examples. So in the United States, a teacher went to a conference in Dallas, which was the city to which a Liberian man who was not yet symptomatic with Ebola but was infected went for first to see his family and then went for care. This teacher, he subsequently died. So this teacher went to a hotel 10 miles from that hospital after the man had died, went back to her home state, and was forced on leave because somehow that hotel was somehow an infection risk. I mean, many more such examples. I have, I think, 66 on the Tumblr today in Ebolanoia. People who were forced on to leave because they went to South Africa, which is 3,000 miles from the Ebola zone. Or in the most recent case in the US, an ambulance crew was summoned to someone who was feverish and vomiting. And 12 of them arrived in full bubble suits, because what they thought they heard on the dispatch was that this person was from Mali, which was at the time the most recently infected country. In fact, the person was Somalian, and there's been no Ebola in Somalia. But their first impulse was to put on their BSL-4 suits before they got in the truck.
Okay, so this is completely irrational fears. I suppose people just misunderstanding the science of it, really, and how Ebola is transmitted. Cliona, can you tell us a little bit about the science of how Ebola does affect the body, what we actually know?
Well, we know it causes absolutely catastrophic response, and that when that happens, I think Colin would be better at actually talking about the symptoms, but from an immunological point of view, when we're teaching basic immunology, what actually makes most people sick is not the virus itself, it's our immune response to the virus. So we have all sorts of mechanisms for detecting infection, and we're probably going to discover more because of Ebola. And when our system detects the virus, it reacts by trying to produce lots of factors and cells for killing off the virus or killing off infected cells. And in the process of that, many of those factors themselves cause damage to ourselves and cause the massive fever. But Colin, I'd say, would probably like to comment to that.
So, I mean, we were chatting a little bit earlier. I mean, it's quite interesting. There are some people that seem to, you know, they test positive, but they look very, very well.
Yes.
And I mean, it's a small proportion of people, but there clearly is something innate in those people's bodies that prevents them from getting very unwell. And we know from some of the limited data that's come out so far that the higher your viral load at the start, the worse your prognosis. So the people that can produce an antibody early on, if that antibody is protective, which again we don't quite know, they may well do better than people that produce an antibody later on, and we see that in a lot of different viral hemorrhagic fevers. I mean, the symptoms that people get are quite easily sort of categorized into about 3 stages, and we're seeing this a lot in the literature, which we never had before. It used to be if you had diarrhea, vomiting, you know, you were saying blood coming from your eyeballs. People were saying before that, you know, that seemed to be what people thought was Ebola, but actually, for about 5 to 7 days, most people get a fever, but it's not a very high fever. They get really fatigued, muscle aches, joint pain, very non-specific syndrome, and a little bit down the line, they get very weak. So you get young men, you know, you've seen probably pictures of people lying in the streets, just prostrate and unable to get up.
But is it fair to say that those are cytokines, the inflammatory cytokines, that are doing that?
Yeah, possibly, you know, very possibly. You know, I think we don't know why people, you know, get such weakness. Is it because of their lack of blood tests? We don't know. Is it electrolyte imbalance? Is it, you know, low magnesium, you know, or low phosphate that's causing the muscle weakness? Is it an inflammatory cytokine? It could well be. Is it something else? Is it a direct viral kind of insult to the muscle? Like, I think we don't know. I would imagine it's inflammatory.
Yes.
But I think we don't know.
But what's fascinating to me is that everything you just said about what the symptom picture looks like is nothing like what I think most people think of as being Ebola, which is bleeding from their eyeballs, vomiting up coffee grounds, you know, bleeding from every orifice, which I think is why. And that comes, I think, from the book The Hot Zone and the movie Outbreak. People have a sense that they know what Ebola looks like, and that's what they're frightened of. But that isn't actually what the symptom picture is like.
Well, so to begin with, it's not. And then some people probably never go on to that. So some people probably just get better after that when they have a flu-like illness and then they get better. Some people then progress to a kind of gastrointestinal phase where they get lots of diarrhea and vomiting, a bit of abdominal pain, a bit of chest pain is reported in the literature, but actually when you press on people, it's right here in their stomach. And they have this horrible hiccuping noise that doesn't sound like an innocent hiccup. It's a really guttural, horrible noise that presumably means their guts have you know, the peristalsis that normally goes through the bowel has stopped working. So they, and then some people then progress on to a sort of confusional state, and those people tend to do very badly. And again, we don't know if it's just lots of inflammation or if it's a direct viral insult on the brain. We don't know. And they get confused and they just sort of sit and stare. And you can spot Ebola patients after a while. They sort of have got what I call an Ebola stare, and they just sit there and you know, they're not agitated. They're just, you know, they're very weak and staring off in the distance, and those people do very badly. And probably in either of the last 2 stages, people do bleed a bit, but there's very little bleeding. We see people bleeding from gums, and we see people bleeding from where we've put IV lines.
So no one's liquefying?
No one's liquefying.
No liquefying. Am I got that straight?
Yeah.
So, Maryn, in terms of how we kind of challenge those misconceptions,
I think this is really a problem because the way that, I mean, as journalists, one way that we would normally combat an incorrect picture of what someone looks like who's ill would be to bring forward an actual victim in a story or in a video report. What complicates that is not just that it's inappropriate to do this to people who are so sick, but also that I think a lot of the picture that we have of the Ebola response now is due to Western journalists sort of parachuting into the Ebola zone with big, expensive equipment and big, expensive crews and sort of doing what in a way really, I mean, to be harsh, is kind of news tourism, and I say that as somebody who's done it myself. We aren't really bringing forward the perspective of journalists who are resident in the Ebola zone all the time. And if we could get their voices into the conversation, I think we'd get a more complete picture of what's actually going on in those cases and also in the societies as a whole.
And so is this where, obviously, you know, it's 2014, we can do things like video blogs and stuff like that. Is that stuff going on at the moment, Colin? Or is it possible to do that in those parts of the world? I mean, is the connectivity there? Is the infrastructure there to do those?
I mean, there's 3G. Is that
working? Is that?
Yeah, good.
Okay.
I mean, there's 3G all over Sierra Leone, so I mean, the infrastructure is certainly there to do that.
No, I just actually had the experience of trying to get someone over there to do that, and he didn't have the connectivity, so maybe...
so I guess it depends where you are in the country. Yeah. So in Freetown,
this
certainly...
This is in Guinea, so I think which is...
Guinea and Liberia maybe... Liberia, Guinea might be different. Sierra Leone certainly
has got very good. You would have the capacity to do that.
In most places, certainly in cities, you would... I mean, the slight challenge is that there are some people that bleed. And it's pretty horrible when they do, and children in particular tend to bleed. Girls get a lot of vaginal bleeding, and it's horrible to see. So, it's not completely, you know, the image people have isn't completely. I mean, what is completely untrue is that your organs liquefy. I mean, that's not the case. When on the very few autopsies that have been done, it looks more like it's a sort of vascular leakiness. So it's the blood sort of leaks out of the blood vessels rather. It's not that people liquefy in any way, but some of the scarier type of symptoms are there, but it's a very small minority. So I think it's really difficult to try and tease out how you get a good message across. Saying, I mean, the countries had this a lot at the start, where to begin with the governments were saying, this is a horrible disease. It's got a fatality rate of up to 90%. There's no cure. Come to hospital. And people were, why on earth would I go to a hospital if there's no cure and I could stay with my family and they could look after me and I'm going to die in a hospital and then my family will never see me again. So, and what I think we know now is that, as we see from people in the States, is that with good medical care and early intervention, without any sort of novel treatment, even though there are some that have been trialled, we don't know what the baseline mortality rate would be in the West, but it probably is about 20% or 25%. It's certainly not
which is not the 70% that you're seeing in West Africa at the moment. Okay. In terms of what's missing in West Africa at the moment, my understanding is that what's needed now to contain or to try and tamp down the epidemic, the outbreaks, the epidemic that's happening there, is more people like yourself, Colin, on the ground who have the expertise and go over and spend a month, training up local doctors, bringing in the testing facilities, etc., etc. And is that the big piece that's needed now to try and contain this epidemic? Is there any issue with what happens when those people come home? We've seen cases in the US, particularly. Sorry, I keep picking on the US. Sorry, Maryn. But you just happen to know a lot about that particular area of the world. And maybe, Maryn, you could tell us a little bit about what's been happening to people when they come back from areas and the quarantine issues.
So this goes into goes to the problem of people having an incorrect sense of what Ebola does and also how contagious it is. And so any healthcare workers who came back to the US having worked in the Ebola zone were asked, and in some cases forced, to go into quarantine. And in the cases of folks at the Centers for Disease Control in Atlanta, after they returned, in many cases their wives or husbands were told not to come to work, and their children were excluded from school until the parent who had gone to the Ebola zone was through their 21-day observation. The most notorious case in the US is a woman who's, she's actually a nurse, I believe, but she was one of the CDC's disease detectives, one of their epidemic intelligence service officers. She went to the Ebola zone, she worked there, she came back, she underwent the mandatory temperature check. She was completely non-symptomatic, but they asked her questions so many times, and she had been on the plane for so long that she just got a little sort of annoyed and warm. And so they said, "Aha, you have Ebola." and she was slammed into an unheated tent in a parking lot, essentially as political theater. In the state of New Jersey, which is where she'd landed. She'd landed at Newark, and she was eventually allowed to go to her home state of Maine, to a town that is on the border with Quebec, around which there is exactly nothing for a very long way, where she was also forced into quarantine, and she defied the quarantine and just walked around this very tiny town and rode her bike with an enormous news crew coming after her, and she was never sick. She never had Ebola. She never developed any symptoms. She only had that one high temperature, and it wasn't even very high. But she became sort of an example of just incredible overreaction for essentially no point.
And is this likely to put people off?
You would think, yeah. I mean, if people are going to be... So in the US, in about a month, 2 months ago, there was the largest medical conference of dealing with tropical diseases like Ebola in the world. The state in which the conference was held told anyone who had been working on Ebola in Africa not to come to the conference because they would not be allowed to leave the airport.
Right.
Yeah.
So,
and Colin, you are back. You were telling me it's 20 days since you came back from Sierra Leone. Is that right? Yeah. Okay. Getting a bit hot under these lights. So can you explain to me what kind of procedures have you had to go through?
So the procedures I went through, I think, were very reasonable. Although they've changed as of yesterday. So me coming back today would be different than me coming back 3 weeks ago. So I went through screening in the airport. So my passport was flagged because the organisation I'm with sent returning details to our public health authorities. So I was screened at the airport.
When you say screened, what does that mean?
Oh, well, they went through a questionnaire, went through a checklist, made sure that I hadn't had any breaches in my use of the personal protective equipment. And then was given a sort of little box with a thermometer and some chlorine granules and a sack. I don't quite know what, I think...
A sack?
Well, it was in case that I vomited and then I could put the chlorine, on the... Which, again, I think, I'm not in any way blaming them, but I think, again, this is the fact that this constellation of symptoms that we think we historically thought was Ebola is not true. I mean, people don't get vomiting until really quite late in the illness, so... you would hope that you would be picked up, certainly on temperature monitoring or something else beforehand. And then I have to monitor my temperature twice a day, and the minute I have any symptoms, I'm supposed to...
there's a helpline you can ring?
There is, well, yeah, there's a... And also, I've worked at the hospital that looks after so I will make my way immediately there, should I get a temperature. And then coming here, I had to speak with the Irish Public Health Authorities.
Okay, that all seems very reasonable.
No,
we're not throwing you in a tent.
It's all very reasonable.
Heat or water.
As of yesterday, our guidance has changed. So any returning healthcare worker who's physically done clinical care will have to, if they do a clinical role, be off work for 3 weeks, which I think is going to have volunteering. The US saw a 25% reduction after the New York and New Jersey cases of returning healthcare workers. And then there will be limits in terms of you're not allowed in a hotel, you're not allowed in you're not allowed in public transport for more than a short distance, but it's unclear what a short distance is. You're not allowed in a public gathering like a concert where you might be. So that's as of yesterday. I think there clearly are political motives for why those have changed, but I think it's yet to be seen whether that will have an impact on volunteering, but it will certainly affect organisations like ours who rely on people coming out for a month at a time.
Absolutely, because you're effectively, if there is a quarantine period after it, you're effectively asking people to give up 2 months.
You're doubling the time, which for jobs is to release people for a month is quite. It's not easy, but it's within a difficult rota. It's doable, but to get people for 2 months is.
And can I ask? And are you scared?
When I'm there, I mean, I think anyone that's not nervous is misguided. I mean, it clearly is there are people that do very badly, and it's clearly not a nice disease to have. So I think when you get used to working in it, I mean, you trust your PPE. As long as you wear it.
What's PPE?
So personal protective equipment. So the full body suit, boots, double gloves, kind of visor. We've not had any infections in volunteers in our unit. We've been working there since May. I think you get into you're always careful, but the fear does subside a bit. But I think certainly there's always in the back of your mind you're working at a higher level of awareness and caution than you would, when you're looking after a flu patient or something.
I'd really like to know, what's your hypothesis for why there's been a higher rate of infection among the local healthcare workers than among the volunteers going? Is it quality of the PPE? Is it training? Is it just that they're so overworked?
So the CDC actually I've been very impressed with in country. They've done a great job, and they're very good people. And so they are looking. They've done a bit of work around healthcare worker infections, and we're starting a study where we're going to speak to infected workers and also to non-infected workers to see if we can tease out the differences. I think there are several reasons. One is that undoubtedly people are treating people at home. Probably I would say 60% of infections. Currently, at the start, it was because the infection control in the country was so limited. I mean, even on it, we've tried this is the major referral hospital in the country that we work in, but TB patients would get put next to severely immunocompromised HIV patients who would get put next to diarrhea and vomiting patients, and there was and the nurse might wear gloves, but she would then wear gloves between all the patients and then eat her lunch with it because she was wearing gloves, so she was protected. We only had running water in half the wards in the hospital. That's better, and there's through quite simple things we were able to do some general infection control, but that's just within our hospital and within the country. So at the start there was not, midwives very high viral load that they've been exposed to. So lots of infections early on in staff just because they didn't have PPE. And unforgivably, even several months in, we still internationally hadn't come together enough to get PPE where it was supposed to be in the districts and in the rural areas. So there was a bit of that, certainly at the start. That's not so much of an issue at the moment. Staff are working at home, either getting paid to look after people in the community, or looking after compassionate care of colleagues who will come to them and say, I'm sick, but I don't want to go to hospital, will you look after me? And we think a lot of staff are getting affected by looking home. Also, a lot of staff work, they live in the communities that are infected, so if you've got infections within the local population, then a lot of staff get infected through that route. So there's no doubt that some of it they're getting infected at work, but I think the infected at work bit is a small component, particularly in places where they work in tandem with international partners who really have very strict levels of infection control. I think maybe some national centres that are left, unattended without supervision, because there's not been the history of really, really good infection control. Things may still be a bit laxer there. But by no means, the Sierra Leone military are running a lot of the treatment centres, and they're excellent. So I think it's all the exposure outside in the community, either through patient care or through just living in the communities that have.
I suppose one of the things that strikes me about this, and this is what I've read, is that the really important thing to do now is to tamp down the outbreaks in West Africa. We've already seen a few sparks coming out from that fire elsewhere that have been reasonably well managed in the US and Spain. I think Nigeria managed to keep control on it. But until we get rid of that fire in West Africa, this is just the whole world is going to have to be on alert for this. There's a slower burner too, which is the vaccines and treatments in development. So while the vaccines probably wouldn't be of huge use in West Africa at the moment in terms of dealing with the people who have already got the disease, what is happening at the moment with those vaccines?
Well, it's interesting that you should use the word slow. It's typical for science progress that we have to use the word slow, but this scene has been absolutely remarkable in recent history, that it has moved so quickly for science. We still know very little, but you have a community of researchers from across the globe coming together and meeting and exchanging information, and we now have two vaccines in clinical trials.
Are there a couple of others coming along?
Yes, and many others coming
through. And actually, I think I read that one of those trials was postponed today.
Exactly, just today.
Some people were complaining of joint pain, so they wanted to make sure this wasn't as a result of the trial.
Because some other trial, if you have to stimulate, because you're using a virus to actually carry the antigen, so the virus itself, the adenovirus, is stimulating an immune response. But one of the vaccines is being led by an Irish Dr. Adrian Hill. Yes, exactly. So, but we were talking about the difficulty of actually trialling the vaccines. And I mean, there's one one thing about injecting a vaccine into healthy people and looking at their ability to be able to make antibodies or T cells, but how do you know that it's actually going to work? Only if they get exposed to the virus. And of course, that's ethically really difficult.
Yes.
And so we had a very interesting conversation about the problems. Yeah.
So I mean, there are all manner of problems, I think, with both the treatment trials going on and the vaccine trials. I mean, they're very worthwhile, absolutely kind of key to know if it works. But there are challenges because, you can't expose people to Ebola once you vaccinated them. So you have to look at the group that's most likely to be exposed, which are healthcare workers. So then you need to vaccinate enough of them to be able to see an effect on either other healthcare workers who are not working on the front line, or compared to sort of the historic levels of infections that they have had.
As scientists talk about the control group. You need to have a...
And so the control group is very difficult, and even the case group is very difficult as well, because you need to know that the people you vaccinate are the people that are actually on the front line and have the risk exposure that we just talked about. So we don't know where, like, a lot of the people may be getting infected in the community, and maybe just things will change in the community. Actually, maybe healthcare professionals, because they're getting much better paid now for clinically working with Ebola than they were before, maybe they will stop treating people at home, and therefore maybe the number of cases will go down, and actually people will misinterpret that to be a vaccine effect, but it's just what was happening.
So I know
anyway.
I'm vastly oversimplifying, but which is what journalists do. Sorry. It sounds as though you can't. There is no way in this situation with Ebola continuing to go forward in the Ebola zone and becoming almost endemic there. It sounds like there's no way to construct a really good vaccine trial. So I mean, how do you do sort of the best with the best that you can with the conditions that you have?
Oh, yeah, it will have to be a huge one and over a much longer period of time, and then you will vaccinate, like the way we do trials in other circumstances. But whether we'll be in time to prevent the next epidemic is a big question.
But already there have been changes to the ethics, to the ethical procedures involved in trials because of Ebola and because of the unusual nature of it. And I think there have been changes as well in the communication strategies of some public health bodies as well, Maryn. I think maybe you were saying the CDC, the Centers for Disease Control in the US, are now becoming much more open, much more porous, I suppose, to information.
Certainly from a US point of view, and I think this is true in Western Europe as well, this big outbreak of this dread disease that people are so terrified of happens to occur at the same time that the news business has been completely coming apart. So there aren't very many people like you and me left in the news business anymore, people who are specialists in science or medicine or public health, which means lots of people rush in to fill that vacuum who aren't really necessarily very well versed in the issues. And as they say, on the internet, you are an expert because you say you are. So in response, I think many of the public health agencies in the US, in the UK, the WHO, and also the individual academic centers that are working on this from a variety of aspects, are bringing forward their own stories. So the CDC, for instance, has been running online video interviews with its scientists. They would never have done that 5-10 years ago. I think having covered them for a long time, I think first they would not have thought it was their task to do, but also they would have thought of it as sort of a diversion from the main job of actually doing public health. And things like this and like SARS a few years ago, have, I think, convinced public health agencies that they have to come forward and tell their own stories because they can't trust that anyone else is going to get it right.
Absolutely, and I think the nature of Ebola as well, and the responses to Ebola feed probably into a very fast news cycle as well, which doesn't help when you're trying to get the nuances and the facts and everything. Well, obviously you have to get the facts right, but understanding the bigger picture as well is quite difficult if you're just thrown onto an Ebola story and here, go do that.
But I think there is so I think the vaccine trials have moved way faster than any trials before, and there was a nice article by a infectious disease guy, I think from New Orleans, in Politico, and he said, from a humanitarian point of view, the aid agencies think they're moving incredibly rapidly. They're moving, more, maybe not even from a humanitarian, but from a development point of view. So it's a lot like DFID in the UK, or in Sierra Leone in a very big way. That's our Department for Foreign and International Development, and they are they've really heavily invested and they're doing a very good job. But the guy in the article says, we're not moving at virus time. So right. we think we're moving Earth, shatteringly fast, but we're not moving in response to the virus. So, we set up. When I was there in June, we looked at lots of hospitals and looked at their preparedness and tried to make sure that they had a triage process for identifying risk patients and getting them isolated in an appropriate area and staff trained. And a lot of that, sadly, when the first cases came to Freetown, sort of fell apart. So we had to revisit that. So in four other hospitals, we put up an isolation unit, either in the hospital or attached to the hospital. And the costs of doing that, they're not big. These are sort of areas where people get tested. Treatment started, and then if they test positive, they get shipped to a dedicated centre, or they get moved into the general hospital if they're negative. And they're not big, between about 10 and 20 beds each, but we set those up for an average cost of £10,000, and with a lead time from start of construction to first patient of 7 to 10 days.
Wow.
So the response that you're seeing, and we've now seen 1,000 patients over the last 2 months in those 4 units. So it doesn't have to be as difficult as I think aid agencies are making out. And you're getting a lot of people coming in now who they're not infectious disease specialists, they've not worked in this environment before. They very, very reasonably, on one hand, are being ultra, ultra cautious, but actually you don't need to do everything. You don't need to make the best unit you can get. You just need to have one that has got good safety standards and good infection prevention and control. And actually, if you think through the logistics of it appropriately, and you have a little bit of expertise, then you can do things really well. But I think that gets back to your point about who we need on the ground, in that we need people. A lot of the people that are doing training at the moment are people that have not actually worked inside a unit themselves. So what we need is people going for a month, working in a unit, getting all of that experience, knowing some of the pitfalls, and then going out and going and training local staff, or helping construct, or helping oversee other units. But a lot of the models that we have for sending people out don't allow us to do that, because it's just short-term people that constantly
Ebola
change.
just seems to be a mold breaker, doesn't it? Between understanding how the immune system works, developing vaccines and trials, even the way we communicate. Yes. It's really shaking everything up. So I suppose maybe while Ebolanoia is the almost parody end of that fear, I suppose it also has positive effects on how there are probably things moving on from this that will, I hate to say, bleed out into other areas, but will have an effect maybe on how we do trials with other viruses, etc. Yeah. Because obviously Ebola is not the only gig in town. There are a lot of other emerging infectious diseases, and as our antibiotic stocks go down, and as antivirals have always been an issue. Viruses are very difficult to tackle. Yes. Hopefully, what we learn through Ebola will actually help in other aspects as well.
Unfortunately, from what you're saying, it sounds like we're going to have a long time to learn from Ebola. It's not like this is going to be shut down anytime soon.
It's going to keep coming back, and in a different form. That's the whole thing. It's about it changing rapidly as well. The first one that came out in 1976, when they've looked at the sequence differences, there are significant differences. Mm-hmm. Some are conserved, of course. Even the shape of the thing is weird.
It is
for a virus. Anybody who didn't know, you'd think it was a worm.
You would.
From all the diagrams, but it's not. It's a virus. Yeah. So that means there's hundreds and hundreds of thousands and thousands inside in a single cell, and that's how it actually replicates and what it's actually doing. There's a whole raft of research to be done. Yeah.
To give people an example of just how much virus, so if someone's got a very high viral load, that's probably 10 million viral copies per milliliter of blood.
Per mil.
So 1 cubic centimetre of blood has got, that's a high viral load, but there's lots of it. But no, I think it's not going to, I think again the aid response seemed to. Some people think it started like this and it's going to come down. I think the problems that initially when it was in Guinea, it was a Guinean problem, then it was a Liberian problem, then it was a Sierra Leonean problem, and then subsequently Mali and Nigeria and the US, etc. But at the start, the initial messaging was in official languages just in those 3 countries, and there wasn't a regional response. But there's an ethnic shared group around the sort of intersection of Liberia, Guinea, and Sierra Leone that were the predominant ones affected at the start. They actually aren't that infected anymore. It's mainly gone from there, but there will probably be other shared communities across. So until it's controlled in all 3 countries, you probably will see a bit of bouncing back and forth. And Kenema was where the Lassa fever centre was, which is another viral hemorrhagic fever that is endemic to West Africa. And it had a spike around July, lots and lots of cases, and then hadn't seen any. Then there's one funeral, and funerals, as ever in the world, they're very important, and people wash and kiss and bless the body, and then as a blessing for family, they wash in the water that the body's being washed at, which in terms of the vehicle for transmission is huge. So in one funeral, there were 40 cases in an area that hadn't seen cases for a long while. So I think you'll see a really low tail end with a little, with bits of spikes, and so I think we'll get in control. Hopefully, I would hope by the end of kind of this year. So by January time, we'll start to see a reduction in cases in Sierra Leone. But I think it's going to. And
in terms of, because obviously there are very deeply rooted cultural and social practices that facilitate the transmission of Ebola when somebody is infected. And how do you tackle that in a way that's not like, we've arrived, we're going to solve the problem, you have to do this? I mean, that must be very difficult for everybody involved.
So there's a worry, like Liberia probably really is seeing a decrease in cases, but there was a worry at the start that about 3-4 weeks ago when they first reported it, that actually it was that people were staying at home and hiding because the somewhat through the American government said that they were cremating bodies as a matter of course, and that is very, like, cremation is not a cultural practice there. So there were worries that it was so alien that people were kind of staying at home and hiding. It's been going on long enough that probably it actually really is a decrease. But there's worries in Sierra Leone, for example, that every person that dies now gets a safe burial. So that's a burial team that comes out in full personal protective equipment and goes and buries. At the start, there were not enough, so people were burying their relatives because the mother had been lying in the street for 2 days, and there was no team. So so at the start for several months, and again, I think largely unforgivable from an international response, that we didn't help them scale up that capacity quickly enough. But there is now good capacity. But there's anecdotes that the equivalent of 999 that people call, they will sort of do a lot of the blessing rituals at home, then call the person, then that person will get picked up, will get buried in a sort of safe manner, and that'll be a safe burial. But actually, all
the infection risk has already taken place.
And they know that that there's a risk, because that's why they phone up afterwards. But it's such a deep. It's saying goodbye to the loved one, and it's such a deep thing. And how do you?
Such a traumatic time as well. I mean, to have these things imposed on you must be horrific. The amount of human suffering is just.
So there's that bit at the end, and then the upfront bit is in that muscle achy fever, febrile stage. Most people think they've got malaria, or hope they've got malaria, even if all their family has died of Ebola. And it's not unreasonable for you to think. And we're heading into malaria season, peak time now, and it's not unreasonable for people to think, oh, I'll just take some antimalarials. But probably if they get rigorous intravenous hydration and a bit more symptomatic relief, then they may well do better. And if we do get drugs that are available, getting them early will help. So how do you get people to come early?
So do you think new educational or outreach elements, if you say there's 3G all over the country, do people have phones? I mean, could we be using Vimes or something to communicate new
So lots of people have phones, and they're trying to do that. I mean, I don't know from your experience about if there are good media messages. There are lots of people doing community mobilization, but I think everyone knows about Ebola now. It's not. I think at the very start there was a bit of fear. In the east of Sierra Leone is where the civil war remnants, where the rebels were, and they also represent the opposition party in the government. And there was concerns that the government were killing people off early on.
Yes.
There was a lot of mistrust that Ebola was not real, and the government were sort of secretly taking people away, and killing them. That's not the case at all anymore. Everyone knows. And so I don't know what.
So I know for some other diseases, like for instance for H5N1 avian flu, there were really good models put out of how to use SMS as part of kind of public health communication across the country. That you could push texts to everyone's phone, or you could create programs in which you created incentives for people to text back to the public health authorities when they see cases, or in the case of avian flu, it was when there was obviously a sick flock, that there would be incentives for people to report those, and so they could get a sense of sort of the epidemiology on the ground really rapidly with the help of mobile phones. But that doesn't really solve the cultural problem, I don't think, and it also doesn't. Maybe I shouldn't raise this since you're working with the Sierra Leonean authorities, but it is a country that's well known for for having problems with aid going missing,
and
it
absolutely.
scores very high on corruption indices. So I think there are questions of trust and mistrust and misspending that are really dogging the effort as well. So, SMS won't fix that.
Well, it just remains for me to thank our panellists, Professor Cliona O'Farrelly, Dr. Colin Brown and Maryn McKenna for, I think, what has been very enlightening discussion this evening. So, round of applause.